step up forward. This was a lovely case and great discussion. Big hand for you. So now we are going to talk about what kind of balloons role would be in calcified cases. So Sanjog is going to try to thread the needle.
Thank you. And I will do my very best, but I'm going to, this is a fun talk because it's provocative, right? We have a gazillion years of interventional cardiology experience throughout this crowd when you combine all of the highly experienced operators. So I'm going to ask a very simple question. How do you know your NC balloon is going to work? Or how do you know your cutting balloon is going to work? I mean, presumably you picked it because you thought it would work. You didn't just want to spend $900 of the hospital's money on nothing. So why did you pick it? What is it in there that tells you this is what's going to be the right tool? That's the question that we're going to try to answer. And there was a very nice discussion this morning about imaging and the characteristics of imaging and what it is within your armamentarium that directs you to use a tool. But I pose to us all as interventionalists that we are very much more surgeons than we are the rheumatologists of what we do. And if you talk to a surgeon about what they touch, they are very precise about what knife they use, what retractor they use, and what tissue they'll put their hands on, because everything else is just a nidus for trouble. And so for us, we now need to target our tools to precisely what we're trying to achieve. These are my disclosures. So these are the current concepts in coronary calcium management. This is one of the algorithms from Demaria and colleagues out in Europe. There's lots and lots of branch points, as you can see. This is another one from Europe that looks at a lot of bubbles with a lot more branch points and very difficult to read. And this is something from Optima that looks a little bit like the London Tube map. Looking at this makes me nauseous because I have no idea how I'm going to follow it on a day-to-day basis. I'm not going to sit there with an algorithm and try to work my way through it. And the reality is all of these algorithms are one thing. They're complicated. And calcium is already a difficult thing to treat where you're trying to manage your patient's vitals while you're trying to manage their coronaries. So how do we simplify this? Well, let's simplify this into the algorithm that was built around intravascular imaging by Akiko Mehara and colleagues, where we know from looking at angiographic calcium, if it's present, you need to image it, period. Because the presence of angiographic calcium does not give you an idea of thickness or morphology. It tells you it's there, full stop. If it's not present, do whatever you're going to do, balloon it and stent it, you'll be fine. Because in 91% of lesions in that scenario, you get good MSAs right off of straight stent, balloon, post-ill. Say you have calcium. Now you go into that IVUS algorithm that has been developed where they've looked at points around the morphology of the calcium to tell you when you're going to need some sort of a modification technology. It's 1.7 points on that algorithm where it takes into account the size of the arc, so over 270 degrees, the diameter or the thickness of the calcium, so greater than 0.5 to 1 millimeter, the length of the calcium, so greater than 0.5 millimeters at an arc of over 270, and the presence of a nodule, 1 point for each of those. Over 1.7 points means you need some sort of calcium modification technology, which basically means if you have more than one of these things, you're going to be picking something out of your armamentarium. So what are you going to pick? Right? We have this algorithm here where it says we group scoring, cutting, and OPN together, but are they all the same? Well, clearly not, right? We're already talking a little bit about when to use OAS, when to use ROTA, when to use these kinds of things, but why do we lump these balloons into the same blob when we know that they cost different things and sometimes one will work, sometimes one won't? Is it time for us to ask the question, when do we use which tool, right? It's sort of shocking that we're asking this in 2022 when we've had these tools for a long time. So these are the open questions. Which lesion do you use what balloon? Do you use it after atherectomy? Before atherectomy? Both? What about the safety and pressure advice? Is it safe to take, everybody from Boston Scientific plug their ears, is it safe to take a Wolverine to 20 atmospheres? Is it safe to take an OPN to 50 when the rated burst pressure is 35? When do you use it and where? Will it pass? Or is your administrator going to be down your throat about opening a multi-$100 balloon and then promptly throwing it away because you couldn't get it to the lesion, right? How many pulses do you use if you're going to use IVL? Where do you put the pulses? Do you line up the emitter on the lesion, between the lesions, at the thickest part, on the nodule? What about how you prep the balloon? How perfect does the contrast prep have to be in an IVL to really get sound transfer? How does that differ from a cutting balloon where the consequences of rupture are huge if you leave an athertome behind? And what about cost? Particularly in the environments outside of the US where we're not made of money and we don't run an insurance-based program. So there's a lot of questions here, right? So let's start with the OPN balloon for a minute. This is a dual-layered Kevlar balloon where the primary piece is the ability to impart pressure upon your lesion. So the question that should then come up is, okay, when does pressure matter? As opposed to when does the strength of each hit matter? And that's where we start looking at the data around OPN usage. Let's look at this case briefly. This is an inferior STEMI, okay? So not something where you think instantly you're going to rotablate. We rotoblated because I couldn't get anything through. So we rotablate down distally, used a 1.5 burr, 6 runs, and got a reasonable expansion result within the distal vessel. It's a 3.5 NC balloon. This was at 20 atmospheres. I thought this was expanded. I was completely wrong because then I put a 3.0 by 48 millimeter DES distally from the RPL back into the right, and you can see proximally here, I'm in a world of trouble because now this is underexpanded in a distal right in a lesion where the patient's already got activated plaque everywhere. But I wasn't that worried because fear not, I took an OPN balloon, but before I took the OPN, I imaged this. What does this IVUS tell me? You've got an almost 360-degree arc of calcium. That should worry you, right? But you've got natural reverberation here, 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 and here, which means this is thin calcium. This is less than 0.5 millimeters thick. And we know, based on data around OPNs, that high pressure is going to work here. And that's why after an OPN balloon inflation, this is the result I got. So why wasn't I worried specifically? So this is data from ISAR Calc in 2021, where they actually looked at NC balloons, OPN NC balloons specifically, and tried to develop a receiver operating characteristic curve using imaging to figure out where they work and where they don't. And what they learned was that when your arc is over 227 degrees. So you actually need enough arc of calcium to be able to impact multiple sides, because remember what you're trying to create is cracks in different places. When you impact multiple sides, you create fulcrum cracks. You create multiple stress points. And what you need to know is that your calcium needs to be less than 0.67 millimeters thick. So if you're going to get that precise, OCT is probably your best friend. But what you can use IVUS for here is the dichotomous decision of presence of reverb or absence of reverb. No reverb means thick. Get ready to use something else. Presence of reverb means relax. You're going to get this open 100% of the time. Okay? And so OPN balloon efficacy, your high pressure efficacy is a function of calcium arc and thickness. So when do you select an OPN? You select an OPN if your calcium thickness is less than 0.5 millimeters on IVUS or 0.5 to 0.7 on OCT, or if you have an underexpanded stent, in which case you take an OPN at 0.75 or 1-to-1 of the vessel size and you take it to town. 35 atmospheres, because what you're trying to achieve is pressure. You're not trying to achieve size anymore. The size you did. This is all about creating crack. What about Wolverines? So this is a true non-compliant balloon. This is the NC Emerge balloon with 2 triangular-shaped athertomes that allow you to put pressure on specific sites at high levels. But it does not treat multiple areas. It only treats the 2 areas that are across from one another. Although it's easier to deliver than the OPN, and it's much more flexible than the OPN. It's much easier to get to the site of action, goes around corners nicely. So this was old data where they randomized people to cutting balloon and stent versus PTA-CA and stent, and they see that their restenosis rates are lower in cutting balloon angioplasty, but this was just before pure angioplasty, right? Or this was just while there was pure angioplasty. So let's look at this case. So here we've got yet another one where we had to rota this to get anything down because there's something in the water in the north part of Ontario. And we took a 4.0 NC balloon after rotaing this, and the 4.0 NC balloon failed to expand. So we imaged it, and then ended up taking a 4-0 Wolverine, which did a nice job of expanding, as you can see, and yielded this final result. And once again, when you look back at the IVUS, what do we learn? We learn that in the IVUS, you can see multiple cracks, right? Okay, and there's reverb here, there's reverb here, there's a crack here, and there's a crack here, right? And even at this very, very tight point, you can still see shadowing and reverberation behind the calcium. So this is, relatively speaking, thinner calcium. This is, not surprisingly then, what a rota cut strategy looks like, where you've got point cuts at the thinnest parts of calcium. So how do we use this information to guide our decision making? Well, in this series, this is brand new, 2022 data. Okay, this was in Circ Interventions a couple of months ago. When you look at the calcium angle, thickness, and balloon to lumen ratio, your receiver operating characteristics tell you that these are going to work best when your arc of calcium is about 200 degrees or less, and when your thickness is less than 0.445 millimeters. Okay, so slightly thinner and slightly lesser arc, but that's good because these are easier to deliver, and so those are the ones that you target. So when do you use this? For moderately thick calcium and for suboptimal or minimal crack formation after atherectomy. What about Shockwave in my last couple of minutes here? Shockwave, this is a brilliant technology. This is my friend Lorenzo Azzolini. These are his fingers, right? So this is shocking his fingers, nothing happens, but then you shock the cement and it blows up in front of you very nicely, right? So when you look at the little evidence that's out there, right, the Disrupt CAD trials, this works. There's no two ways about it. It works and it works well, though there are a number of open questions that need to be answered, right? When you pool these things, you do have a rate of flow-limiting dissection, and my own personal experiences, there is a good deal of slow flow when you use this in highly plaque-filled arteries and fibrotic lesions, so you need to image it first to be careful and know what you're doing. But this works very well on thicker calcific lesions. So your multi-vessel PCI with Impella support in this less than 20% patient, let's say you don't have an Impella, these are the patients where no reflow, slow flow, these things have serious consequences. And so in this type of an individual where when you image it, you see this, okay, you see big, thick calcium, but now you've created a bunch of fractures as a result of the initial balloon dilatations, with one area here in the proximal part of the vessel that's still a 360 degree that really doesn't have much in the way of fracture. That's thick calcium with no reverb. That's where you take your IVL. That's where you're going to get your best result. And so these are the issues in the Indian, Canadian, non-US environments with IVL. There's virtually no learning curve, but it's expensive. It's very useful on thick calcium, but you bet the farm on it. It's lower risk on curves. It's tough to get there. Oh, and did I mention that it's good for difficult lesions, but it's expensive? So we've got to target our tools to where they really work, because the reality is we need to make sure we get the best results for our patients, and every patient that we waste money on is one patient that we can't treat later. So where do we use IVL? This is the IVL algorithm, where when you've got thick calcification, or you've got an underexpansion concern as a result of nodular calcium or thick calcium behind the stent, you can try laser with contrast, or you can stick an IVL in there and get your job done. Both ways, you're going to end up spending money there. So the take-home points are: one, image, 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 image. Because this is no longer about let's try it and hope that it works. This is about target your tool to precisely what you're trying to achieve. Target your cutting balloons to thinner lower arcs. Target your high pressure to modestly thick higher arc. Target your IVL to thick calcium, because that's where it works. And remember that these tools are highly versatile, but you will be most impressed when you walk in there, you take your targeted tool, you get the result you want, and your case is done in 30 minutes instead of an hour and 30 minutes, because you went through one balloon instead of 6. Thanks very much. Sorry about going a few minutes long there.
That was an excellent overview. So many insights. And we have a comment, Dr. Haney.
I actually have a general comment and a special thank you. I just want to say that, honestly, in the last hour, if you blink, you lose information. and I have learned so much today. I just want to say one point, and I want to thank Sanjog. He was sitting next to me now, and he told me about my case, the question that you asked. He said, if I wanted to rotablate your case, I would have put the rotablator wire down the diagonal and rotablated the LED down the diagonal to avoid going in the rat tail LED. You know, I learned a new trick from somebody half my age. Thank you. And thank you all.
Thank you, Dr. Raghi, for those comments.
For those
That's very
people-
kind.
For those people who have blinked, we'll have a recording posted on the YouTube. We'll put it on the YouTube after a few days.
There are
But please don't blink.
Yeah, there are two new developments in IVL coming. The pulses are going to be 130
Pulses are going up.
and forward-looking IVL. That means you have like a sound bite wire for CTO.
Yeah.
You have one emitter at the tip.
Yeah,
And
that's
that
the
will
smaller
cross
1.5 size balloon that's
Yeah.
coming out. So there are innovations coming. The key is that people are listening,
Yeah.
right? They're listening to us, right? So we have to then keep pushing them.
One question. Despite of doing all these techniques, and if you still find there is under expansion of the stent, how much you accept? Because you have utilized all the techniques. You have done rota, you have done lithotripsy, but many times I have seen, despite of being using all these techniques and cost and all those things, still we find. And I had one case where used rota, used lithotripsy, used even laser, and patient had recurrent. It was single vessel disease of right coronary artery.
Yeah.
So there is no question of sending this case for bypass surgery, but patient was getting recurrent restenosis of the stents despite of using all this technology. So
So that's a great question. So I think you answered the question for me though. What I'm looking for is the 90% distal MLA. If it's not expanded to that degree and there's a substantial reduction from that, I'll rota the stent out. Sometimes when I'm close, I'll leave it. But if they come back, I'll rota the stent out. If that's not working or it's too high risk because of a curve, I'll dissect behind the stent, crush it, re-enter distally and stent over it, which tells me that's probably what I should have done in the first place. And it's amazing how beautifully calcium yields when you get behind it. Right? You go through the media and then you re-enter, it'll crack like nothing.
So let me invite the next presenter.